Thank you for the opportunity to present our work looking at the ideal plane for mesh placement during incisional hernia repair using the Abdominal Core Health Quality Collaborative, formerly known as the AHSQC. The authors have no disclosures and no conflicts of interest. An incisional hernia is the most common complication of laparotomy that requires reoperation in the United States, and as such, repair of an incisional hernia is one of the most common procedures, with an estimated 250,000 patients requiring this repair each year. Reconstruction of the abdominal wall has evolved significantly over the last 20 years. Mesh has become the standard of care for repair of these hernias because it mitigates the loss of domain and helps maintain the rectus muscle's midline, thus reducing risk of recurrence. The impact of mesh initially was demonstrated in a randomized, multi-center study, later supported when shown to have a threefold decrease in recurrence rates when mesh was used, and finally included as the current recommendation set forth by the Ventral Hernia Working Group. Mesh can be placed in multiple anatomic locations. Onlay repair places the mesh on the anterior fascia, which typically involves dissection of flaps and primary closure of the fascia below the mesh. Inlay repair places the mesh in the hernia defect and secures the mesh circumferentially to the edges of the fascia. Sublay repair refers to retrorectus or preperitoneal mesh placement. Finally, underlay repair is when mesh is placed at the intraperitoneal position and secured to the anterior abdominal wall. Myofascial release is an anterior or posterior component separation which may be performed as needed with onlay and sublay repairs. While repair of incisional hernias with mesh is now routine, there is no consensus on the best location to place the mesh. The objective of this study is to determine which of these planes can provide superior outcomes in repairing incisional hernias. As many of you know, the AHSQC is a multi-institutional database that is prospectively collected and used to identify areas for quality improvement. Data is pooled across centers through point-of-care data entry to provide reliable outcomes data for hernia repairs. We performed a retrospective review of patients undergoing open incisional hernia repair from 2013 to 2020. The exclusion criteria are listed here. The patients were categorized into 4 anatomic locations: onlay, sublay preperitoneal, sublay retrorectus rectomuscular, and sublay intraperitoneal. Outcomes of interest were surgical site infections, surgical site occurrences requiring procedural intervention, and hernia recurrences. The initial attempt at adjusted analysis revealed that mesh placement and myofascial release are perfectly confounded in some of the groups within the data. Due to confounding of myofascial release, 2 adjusted analyses were conducted. A subgroup analysis was performed where one group was onlay compared to sublay retrorectus, and a second group where myofascial release was excluded to allow for comparison of the 4 groups. There was a low sample size of patients in the sublay intraperitoneal and sublay preperitoneal groups when myofascial release was used. From the initial 63,000 patients, 6,613 patients who underwent open incisional hernia repair with mesh were identified. Of these, 845 patients underwent onlay repair, 1,005 patients underwent preperitoneal repair, just under 4,000 underwent sublay retrorectus, and just over 800 underwent inlay. On univariate analysis, patient characteristics and comorbid conditions were largely uniform across groups, as shown here. Of note, the median hernia width with both sublay intraperitoneal and sublay preperitoneal was smaller, with a median size of 3 centimeters, compared to onlay at 6 centimeters and retrorectus at 10 centimeters. The unadjusted analysis did not identify any differences in perioperative outcomes of interest. This finding is depicted here for the group with myofascial release. As you see, looking at the odds ratio for this group, where you can see recurrence, surgical site occurrences requiring procedural intervention, and surgical site infection. You can also see the same findings here for the group without myofascial release. In the adjusted analysis, when looking at the group that underwent myofascial release, we did not find enough evidence to support a difference in wound complications with either surgical site infections or surgical site occurrences requiring procedural intervention between mesh placements. For the group that did not undergo myofascial release, there was no evidence to identify an association with mesh placement and surgical site infection. However, there was evidence to suggest an association between surgical site occurrence requiring procedural intervention and mesh placement. In looking at this here, we can see the association between mesh placement and surgical site occurrence requiring procedure when the mesh is placed as a sublay mesh in the preperitoneal space. In a population of patients undergoing elective open incisional hernia repairs using a large national registry, these results suggest that sublay preperitoneal mesh placement is protective for incidence of surgical site occurrences requiring procedural intervention at 30 days compared to onlay, sublay retrorectus, and sublay interperitoneal in a subgroup that did not undergo myofascial release. It is important to note that in patients studied within this national registry, there is no evidence of difference in hernia occurrence in any location or subgroup. Thank you for the opportunity. I'm happy to take any questions.